Welcome to the GRAPPA Global Educational Seminars. My name is Philip Helliwell. I'm a rheumatologist in Leeds in the United Kingdom on a lovely sunny spring day. Today's seminar we're going to discuss assessing disease activity in clinical practice. I'd like to thank Pfizer for their support they've given us to help us produce these seminars. Next slide, please. So this is our agenda for today. Very importantly, we're going to have the patient perspective first up, and we're going to hear from Jeffrey Chow from Hong Kong and Martin de Wit from the Netherlands. Straight after that, pre-recorded video, there'll be a pre-recorded video on psoriatic arthritis by Katie Leung and Laura Coates. Katie is an associate professor of rheumatology and immunology in Singapore. Laura Coates is an associate professor of rheumatology in Oxford in the United Kingdom. We'll have a panel discussion following that, and it's important that this is interactive, and I'd like to invite you all to put some questions on the chat for our discussants to discuss and answer. Following that, we'll have the psoriasis presentation by Joe Merola, who's a professor of medicine and dermatology and rheumatology at Harvard in the United States, and Christina Callis-Duffin, who is a professor in Salt Lake City in Utah in the United States. Christina won't be with us today, but Joe will be with us for the discussion. And finally, we'll have the axial spondyloarthritis domain discussed, and the speaker will be Atul Deodar, who's a professor of medicine in Oregon in the United States. Atul won't be with us today either, but we'll have a discussant, Ashish Mathew, who is an associate professor of clinical immunology and rheumatology at the Christian Medical College in Vellore, to help us discuss axial spondyloarthritis. This should all be finished in 1.5 hours' time, hopefully. Next slide, please. These are the faculty disclosures. Next slide, please. So let's move into the first session. And we're going to have, before and after each session, a couple of questions, MCQs for you to answer to test your knowledge, and increasing knowledge, hopefully, after the presentation. So we'll go straight into the first question, please. And you may find difficulty seeing, but on the left-hand side, next to each of these answers, is a little button that you can click on. So the first question is, which one of the following measures assesses the impact of the disease rather than disease activity? Your options are the PSARC, the PASDAS, the PSAID, or the MDA. So please vote now. I'll give you 5 seconds to press that button. 5, 4, 3, 2, 1. So the poll has been closed, and these are the answers that we have. The majority of people have correctly voted for the PSAID, a few for the PASDAS and PSARC, and a few for MDA. Next question, please. So the next question is, which items are included in the RAPID-3 assessment tool? Your options are, number 1, tender joint count, swollen joint count, and PASI. Number 2, the global VAS, the pain VAS, or the MD-HAC. Number 3, the MDA and the PSAID. All these acronyms will be explained, of course, in due course. And number 4, the tender joint count, swollen joint count, and enthesitis. So I'd like you to vote now in 5, 4, 3, 2, 1 seconds. Thank you. And the majority of people correctly voted for number 2, the global VAS, pain VAS, and the MD-HAC. Thank you. So now we'll move on to the 2 videos, pre-recorded presentations. The first, you'll hear the 2 patient partners discussing among themselves, and then we'll move straight into the psoriatic arthritis presentation by Katie Leung and Laura Coates.
Hi, I'm Jeffrey Chow, a patient research partner from Hong Kong. I was diagnosed with PSA in 2003, and now I need to see the doctor every 6 months with my blood test every 3 months. I'm also involved in a PSA patient group with more than 100 members.
Hi, Jeffrey. My name is Maarten de Wit, and I live in the Netherlands. I have psoriatic arthritis for more than 40 years. And I also have 3 children who are affected with psoriasis. And one of my children also is diagnosed with psoriatic arthritis. Jeffrey, I was just wondering, if I ask my children what their physician told them, there are always several questions for which there was no time during the consultation. How is that in Hong Kong?
From our experience in Hong Kong, time is very limited in every clinical visit. Patients may find it difficult to articulate a full picture of their health situations to the doctor right in the meeting. I think it will be good for patients to have the chance to write down their situation, maybe with the help of some sort of forms or questionnaire, and give to the doctor beforehand, just like we do with our blood tests. The physician receives the result also before the consultation. I think this practice will save time and give a fuller picture of the patient's health situation. Martin, do you see a solution for the lack of time?
Yes, I think that the use of a kind of form, as you said, or a kind of patient questionnaire could be very helpful. It could save time and improve the conversation between the physician and the patient. And for instance, the PSAID, the Psoriatic Arthritis Impact of Disease Score, has been specifically developed by patients and for patients. And if a patient fills in this questionnaire before a visit, the answers can function like a kind of agenda for the consultation. And in the Netherlands, there are several hospitals that are collecting this kind of information online by use of a tablet in the waiting room. And the treating physician can immediately see when there are problems and so what needs to be discussed. And then it might also become visible that the opinion of the patients is sometimes different from that of the physician. Jeffrey, do you recognize this discrepancy in the assessment of the health situation between the patient and the doctors?
Yeah, our patient group does have this kind of discrepancy experience. One of my patient members felt that his situation was getting worse because of the fatigue, pain, and the extent of damage in some joints that was getting more serious. However, the doctor, based on those test results, which showed that all the indexes are satisfactory, designed to keep the same medical treatment without any changes. Because the next clinical visit will be in a few months, the patient worried that his situation will continue to deteriorate.
Yeah. Well, I agree. And I think even when a change of medication will maybe not be the right answer, I think the physician can think about other, probably also non-pharmacological options to address the remaining symptoms of the patients. Yeah. And maybe also consider referral to other health professionals. So thanks for your answers and for this talk. And I think it was a great opportunity to share some of our concerns from a patient perspective.
Good day, everyone. My name is Katie Leung. I'm from Singapore General Hospital. Welcome to this Grappa Spartan Global Education virtual seminar. Today, me and Laura Coase are presenting to you how to assess disease activity in clinical practice for psoriatic arthritis. The assessment of disease activity in psoriatic arthritis can be challenging because of the diversity in manifestations. Psoriatic arthritis can affect the peripheral joints, including the distal interphalangeal joints, and also the axial joints. There are also enthesitis and dactylitis, the skin disease and nail disease. It can affect the quality of life and physical function, and of course the other comorbidities. The outcome measure in rheumatology, OMERACT, has developed a framework to describe measurement in clinical trials. Very easy concept is what to measure and how to measure them. The GRAPPA has spearheaded the PSA core domain set update in 2016, incorporating the opinion of doctors as well as patients. In this onion, you can see that in the inner circle, there has 8 domains that has been graded as important to be measured in every clinical trials. And now we are also doing the PSA core measurement set using this very stringent criteria, OMERACT filter 2.1. And you can see that some of the instrument has been going through this filter 2.1 to be endorsed. I'd like to highlight to you that there are differences in the purpose of assessment in clinical trial as compared to clinical practice. In clinical trial setting, we are assessing disease activity in different domains for the purpose of monitoring the drug response. Whereas in clinical practice, we are doing a comprehensive examination to understand the psoriatic arthritis disease and the impact to patient. These information are necessary to make a judgment to see whether the treatment is appropriate or needed a change. As for measurement in clinical practice, we also look at what to measure and how to measure them. What we are measuring is muscular disease activity, including that in the peripheral joint, enthesitis, dactylitis, spine, and skin, and the impact of disease. Here is some of the examples on how to assess them. But the main purpose of this assessment is to see whether this patient is active in the disease or not, whether the treatment target is achieved, how is the impact of the disease, and that's help us to make a decision whether the treatment is appropriate or needs some adjustment. Of course, life can be easier if we have an HbA1c as if we have in diabetes. However, we don't have that in psoriatic arthritis. The traditional ESR and CRP are not elevated in many patients who have active disease. From our systematic literature review, we find that these two biomarkers are not perfect for the assessment of disease activity. For assessing disease activity in the peripheral joints, physical examination remains very important. For psoriatic arthritis, we are looking at the 66 swollen joint count and the 68 tender joint count. I can understand the sentiments of doing a 66 and 68 joint count in a very busy clinic. The question is whether reduced joint counts, such as the 28 joint counts commonly used in rheumatoid arthritis, can represent the disease activity in psoriatic arthritis. Showing in these two graphs are data from the TACOPA trial. Red are those covered by the 28 joint counts, whereas you can see the blue are those that is missed in the 28 joint counts. So majority of the time are joints in the lower limb that has been missed. So in OMERACT term, the 28 joint count is not having the domain match necessary to measure the disease activity in psoriatic arthritis. Here are some tips I can offer for doing the joint count, enthesitis, and dactylitis in very busy clinic. The first thing to do is get the setting right. I always find a foot rest, so the patients will take off the shoes and rest the leg on it before you examine them. So with some training, the patients are more likely to be willing to take off the shoes and let you examine. The second thing to do is develop a system in physical exam so that you are not going to miss out things. So I always start with wrists and fingers, and I will always observe the symmetry of the digit for dactylitis. Then I go up to the elbow, so I will remember the epicondyles for enthesitis. Then I go up to the shoulder and not forget the supraspinatus there, and then the sternoclavicular joint and temporal mandibular joint. Then I go down to the knee. There are some enthesitis points around the knee as well. Then I go down to the feet and also have a look at the symmetry of the toes for dactylitis. then not to forget the Achilles and plantar fascia. Then I get the patient to stand, and then I examine the anthesial points around the hip. With more practice, you will be more familiar with the system and not to miss anything. I think visualization helps a lot in the documentation process. This is what we have in the electronic medical system, that we can indicate with a dot where are the joints swollen and tender. And I can use a stroke to indicate that it's dactylitis. For the enthesitis, I also create some kind of diagram to remind me and check the box. And this kind of visualization always help me to hasten up the documentation process. Of course, in the good old days where we all use paper and pencil, this kind of chalk was very useful. You can also use sticky labels for documentations. For the assessment of dactylitis, the most simple way is just to count the number of digits that are swollen. It is the base of the digit that we are assessing. We also assess the tenderness to say that it is an active dactylitis versus some are swollen but no tenderness. We call it chronic dactylitis. You can do the measurement by using a dactylometer as indicated in this picture, and measurement is at the base of the digit. If you don't have a dactylometer, a simple measuring tape will also serve the purpose. Of course, there is more sophisticated dactylitis indexes that has been used in research. Anthesiocytes are where the tendon insert onto the bone. For the assessment of clinical enthesitis, we put pressure onto these anthesiocytes. So the pressure is just enough to blanch the tip of your fingernail, which is equivalent to 4 kilo per cm square. Listed in this table are some of the examples for assessment of clinical enthesitis. And I'd like to highlight two popular ones for enthesitis, including the Leeds Enthesitis Index and the SPARC. The Leeds Enthesitis Index is very easy to do, only 6 points, including the lateral epicondyle of elbow, medial condyle of femur, and Achilles tendon insertion sites. Whereas the SPARC, you have a little bit more points on every site. So it's always a trade-off between lower number of points, which is easier to do, and higher number of points, which is more sensitive to change. From this point onwards, I will hand it over to Laura to continue the discussions.
Thank you, Katie. So I'm going to carry on speaking initially about assessment of psoriasis. The most common measure is the PASI score, which you can see here on the left, where the body is divided into 4 areas, and each area has a score for erythema, scaling, and induration. That's very widely used, but a little bit cumbersome to use in practice. And in practice, certainly in our clinic, we use the body surface area, where we look at the percentage of the body covered with psoriasis, estimated by one palm being 1% of the body surface area. There are also measures looking at target lesions or a global rating of psoriasis on a simple semi-quantitative scale. When we think about measuring impact of disease, in the core set you can see physical function, health-related quality of life, fatigue and the patient global listed as core domains, but there are additional measures of impact in the middle circle and the research agenda, because there are really myriad ways that this disease impacts on individual patients. In terms of measuring PROs, I think it's a really important part both of research studies and of normal clinical practice. We can do this in a paper and pencil format with simple paper forms that patients fill in either before they come to the clinic, by post, or when they arrive at the clinic. And it's obviously much easier to do that if they're in designated clinics, because then you know which questionnaires to give to which patient. They can also be done on a variety of electronic platforms, sending text messages or emails before the appointment, and patients completing these remotely. One of the most commonly used PROs now is the Psoriatic Arthritis Impact of Disease score, which is a patient-derived instrument that measures impact across a high variety of domains, with the top 12 shown here. These are weighted differently depending on the impact on patients' lives, and there are cut points for disease control or disease impact control that can be used in clinic to get an idea of how much the disease is impacting on an individual. When we think about treating to target, there are a number of different targets that can be used, but the one recommended by GRAPPA is the MDA criteria and the associated very low or VLDA criteria. These require an assessment of joint counts, patient global, pain and HAQ, enthesial sites, and an assessment of psoriasis, most commonly done using the body surface area. Ideally, patients should achieve all of the cut points shown here, but minimal disease activity is defined by achieving at least 5 of these 7 cut points. When we do treat to target using the minimal disease activity, it's been shown to improve outcomes in the TACOPA trial with a higher chance to achieve MDA, joint outcomes like ACR 20, 50 and 70, PASI scores and the HAQ. It also has prognostic relevance, with the majority of patients who achieve MDA having no radiographic progression, and sustained MDA also associated with a protective effect on plaque progression in terms of cardiovascular risk. The GRAPPA app is available free for use for any clinicians and is available in 12 different languages for the patient-facing aspects of this. This includes a calculator to calculate MDA and perform treat to target in clinic, as well as the PSAID questionnaire, which I mentioned before, PASI and body surface area calculators, and a PEST questionnaire to screen for psoriatic arthritis. You can see here screenshots from the MDA calculator, where you enter in the different outcomes in MDA, and on the far right you can see whether patients have achieved MDA, VLDA or neither, and it tells you which items are controlled and which items remain high, so that you can focus your treatment appropriately. This shows screenshots from the PASI calculator, where you can see the different areas defined on a body map, and then when you're scoring the erythema, scaling and induration, there are photographs shown here at the bottom of the screen to highlight a standard level of disease for those different scores from 0 to 4. There are a number of composite measures which are predominantly used in research studies, but are sometimes also incorporated in the clinic. Traditionally, we've used measures borrowed from rheumatoid arthritis, such as the ACR response criteria and the DAS28, but these are not optimal, particularly when they involve a reduced joint count like a 28 joint count, which doesn't reflect disease activity well in psoriatic arthritis. We have newer measures now, the PSARC, which has been used in much older trials but is PSA specific and covers the 68-66 joint count. Newer measures that cover multiple aspects of disease activity across the different domains of psoriatic arthritis, including the CPDI, the PASDAS and the GRACE. And other response measures such as the DAPSA, which focuses particularly on peripheral arthritis, and the MDA target for treatment, which you've heard about previously. Measures typically used in clinic also include the RAPID-3. This was developed specifically for use in clinical practice and is applicable across a number of different types of musculoskeletal disease. This includes 3 dimensions and is filled in by the patient. It measures physical abilities using an MD-HAQ, a pain score, and measures of overall health. And this is combined to give a quick score, which gives you an idea of symptomatology in these patients. It is, however, designed to be complemented by a physical assessment by a physician. When we think about the standard assessments for inflammatory arthritis, This is the ICHOM standard set for inflammatory arthritis, which you can see overlaps quite significantly with the core domain sets produced by OMRACT, looking at pain, fatigue, limitation of activity, and more wider impact of disease. So in summary, when we think about these measurements in clinical practice, it's important that we consider both disease activity and the impact of that disease activity. When we're measuring disease activity, we need to be addressing this across the different domains of psoriatic arthritis, and you can see here suggested outcome measures to assess joint disease, enthesitis, dactylitis, the spine and the skin. These measures in the different domains can then be used as a target of treatment, for example, calculating the MDA criteria, so that we can ensure that we are minimising inflammation in order to maximise people's outcomes long term. It's important as well that we think about the impact of disease, and the easiest way we believe to do this is using the PSAID questionnaire, which covers a wide variety of different impacts of the disease in one relatively simple questionnaire, and this is available in a number of different languages. When we're then making medical decisions in clinic, we're taking into account whether somebody's disease activity is controlled appropriately and whether they've achieved a target of treatment, the level of the impact of disease that they're suffering, any side effects of any treatment, and then thinking about whether treatment needs to be changed and incorporating shared decision making into that discussion with the patient.
Excellent. Thank you very much, Jeffrey, Martin, Laura and Katie. We'll just quickly go through the two post-test questions now, post-presentation questions again. You've seen this before. Which one of the measures assesses the impact of disease rather than disease activity? I'll give you 5 seconds. 5, 4, 3, 2, 1. And we still have 1 or 2 people choosing the PSARC and the PASDAS, but the majority, 90% of you, are choosing the PSED correctly. And the next question, which items are included in the RAPID 3? Is it tender joint count, swollen joint count and PASI? Is it global VAS, pain VAS, or MD hack? Is it MDA and PSED? Or is it tender joint count, swollen joint count and enthesitis? Please vote now. 5, 4, 3, 2, 1. And the majority of you again have voted for the correct answer, which is, as you can see here, the global VAS, the pain VAS and the MD hack. So we'd like now to move on to a discussion of assessing psoriatic arthritis in clinical practice. And you'll see we have panelists including Katie Leung, who you've just heard speaking, Martin DeWitt, who you've just heard, and Ashish Matthew, as well as myself. I'd like you to put your questions onto the chat if you have any. Well, perhaps I can kick off. Here's a question for Martin DeWitt, who I'm not seeing on the panel discussion at the moment. There you are, Martin. So here we have a panelists, as I've just explained, and I guess you can all hear me correctly? Yes?
Yes.
So, Martin, there's a question here. I mean, clearly, we have a lot to assess as clinicians when you come to clinic, and there's a question here that suggests under what circumstances would you like to see a kind of joint discussion between dermatologists and rheumatologists? In other words, a joint consultation between specialties. How would you see that in terms of the patient perspective?
Well,
Well, I think it's a very relevant question. To be honest, I have never been part of a joint consultation, although I must say that there have been moments that I would have appreciated to not only hear my rheumatologist and his advice, but also to hear from, let's say, the other side, from a dermatologist, what they would recommend. And then specifically when the treatment is not satisfying, so considering a change in treatment. And I think that would have been for me a very crucial time to have a joint consultation, to hear from both sides what would work well for my joints and what would work well for my skin. And that's not what's always happening. And I can only remember one time that my rheumatologist had a phone call with a derm to ask his advice. I've never been part of that discussion.
Yeah, I've been running joint clinics for over 30 years, and there's no doubt they are popular with the patient. They are not so popular with my managers, who think we could get twice as much work out of each of us individually, but certainly from a patient point of view, they're a great hit. I've got a question here in the chat from our esteemed colleague, Kurt de Vlam, who asks, is there any data, Katie, I guess this is to you, are there any data about joint and skin self-assessment? And that's a loaded question, because I know, anyway, you answer the question.
I'm not aware whether there is anything on psoriatic arthritis yet, but I think there are some data showing good results for rheumatoid arthritis. And there are a lot of different apps that is able to do it. And then I have seen some new discovery and looking at infrared, and then they put a phone on the hands and detect whether the joint is lighting up. I think those data will be coming up in publications very soon. There will be a lot of these kind of data, particularly when we are all in a state of lockdown during the COVID pandemic. I think that would be interesting and help a lot in the assessment and also video consultation without seeing the patients in every visit.
Yeah, I should say that my interest in this is we have developed a self-assessment tool that's just been accepted for publication in Journal of Rheumatology, and we're developing an app for that. And the initial results are pretty good. As you say, they're good for rheumatoid, and they look pretty good for psoriatic arthritis as well, although previous work by Daphne Gladman's group wasn't all that encouraging. Do you use self-assessment, Ashish, at all?
So I'm just reminded of the clinics back in India where you're supposed to see 50 to 60 patients on a day. Most of the times I kind of generally end up asking the patient if this is 1%. I'll generally go by the BSA, and because I really won't have time to really go into the details of examination of the skin, but and I get fairly a good estimate because the patient knows where exactly the skin lesions are. But as far as the joints are concerned, I'm not quite sure. When I was in Toronto with Daphne Gladman, we had just started virtual consultations with the patients with the COVID pandemic, and I think, and when we saw these patients back, maybe in a month or two, there was quite a bit of correlation, a good correlation between self-assessment and, of course, even in the videos when you ask the patients, you can kind of get a fair assessment. And I think that's a very important point in the current times.
I'm conscious that we are tight for time here. There's a couple of questions there that we haven't asked. There's one from Anand Katz, not to you, Martin, but to Katie, asking, a good thorough joint examination takes time. How do you manage this in the limited time you have available? I can see you have a system. I guess that's what you do. You have the patient on the couch and run through your system. Is that right?
Yeah, usually with you are very familiar with your system, you just go through the system and documenting it in a systematic way that I like the visualization because you can focus on the ones that has been affected on last visit. If you pull it out and compare to now, it usually get you to quicker assessment of the target lesion.
Yeah. And finally, because we'll have to move on, assessing enthesitis, I guess I could address this to both you and Katie and you, Ashish, but how can you distinguish true enthesitis from fibromyalgia?
I think that's a great question. I'll take that straight away because I've been working on enthesitis and it's quite tough to kind of tease out because we know psoriatic arthritis patients do have increased pain and we know that fibromyalgia can be seen in up to 15 to 20%. And more importantly, we do have central sensitization of pain, which could be seen in close to about 50% of patients. So it's quite tricky because clinically, I don't know how much we can differentiate both, and it could be a major challenge, but that's where we have imaging techniques like ultrasound and power Doppler. I think it's work from Leeds, which showed that power Doppler can kind of fairly distinguish between clinical examination of enthesitis and fibromyalgia. And we also have whole body MRI data which clearly shows that there's a poor correlation between clinical examination and imaging.
Yeah.
So if I were to kind of differentiate these two, I'll certainly get an ultrasound and just roll the probe over the area and be sure what I'm dealing with.
We will have a chance to come back to this because I think it's an important topic, and we've got more time for discussion with all of us for the next 2 discussion sessions we have. So I'm going to move on now because we are going to be limited for time. So we'll move into the domain of the skin, and first of all, we'll have a couple of questions before the presentation by Joe and Christina. So the first question is, of all the following phenotypes, all of the following phenotypes are associated with an increased risk for the development of PSA, except only one of these phenotypes isn't. So which one is it? Is it palmoplantar psoriasis, inverse or intertriginous psoriasis? Is it nail psoriasis or is it scalp psoriasis? Please vote now. 5, 4, 3, 2, 1, and finish. So a majority of you voted for palmoplantar, which is in fact the correct answer. Next question. Which of the following statements is true? Body surface area and PASI correlate highly with patient-reported quality of life measures. The PASI score takes into account erythema, induration, scale, and body area involvement. There's a single common PGA, Physician Global Assessment, recommended for use in industry clinical trials for psoriasis, or the PASI functions best when patients have low body surface area. So only one of those is true. Vote now, please. 5, 4, 3, 2, 1. A tricky question, and the majority of you have voted correctly. So you've all been listening hard already. Thank you for that. So we'll move on now to the presentation by Joe and Christina.
All right. Well, on behalf of myself, Joe Merola, and my friend and colleague who will give herself an introduction in just a moment, we're delighted to share this brief portion on psoriasis, looking at clinical phenotypes, differential diagnosis, really for the non-dermatologist, and then I will turn it over for measurement of clinical activity. I'm Joe Merola, dermatologist, rheumatologist here in Boston, and my colleague.
Hi, I'm Christina Calistefan. I am a professor and chair at the Department of Dermatology at the University of Utah in Salt Lake City, Utah.
Awesome. I'm very pleased to be here with Christina. And so I'm going to kick us off with some high-level sort of overview content, looking really at a little bit about psoriasis phenotypes. We have a very short time, so it will indeed be a high-level view, and then I'll turn it over to Christina.
So plaque psoriasis in classic areas, well-demarcated erythematous plaques on the extensor surfaces, I think is, really sort of a largely pathognomonic finding. But let's talk a little bit about some of the lesser discussed phenotypes. I will begin first with a comment about scalp disease. So we know that the majority of our patients have some amount of scalp disease at some point in their disease course, and that's obviously a very important place to look first. The other subsets, or a few of the other subsets that we'll mention, are involvement of the nail, and we'll look a little bit at some of the different specific morphologic features of nail in a moment. Inverse or intertriginous psoriasis, and I definitely want to highlight this as well because it often, I would say, is morphologically one of the more challenging, unless it's unless you're sort of comfortable looking for it and have it at the front of your mind. You may miss this, or it may be misdiagnosed. And then, of course, palmoplantar subtypes and others, which we'll have a look at. So just to take a moment to dive a little bit into this inverse or intertriginous psoriasis, which occurs in body fold areas. This is typically found, for example, behind the ears, in abdominal folds, in the inguinal creases, in the intergluteal cleft, classically. And the reason this is a little bit trickier is you can see it doesn't have necessarily that thick micaceous scale, or it has much more subtle scale. It may simply look like a pink patch or thin plaque, which could sometimes be a bit confusing. In a moment, I'll show you one that was, in fact, went misdiagnosed for many, many years in this patient. So here we see a woman with this submammary or inframammary involvement of a thick plaque with scale. The reason I bring this one up is, an annular scaly plaque is often, particularly in these areas, is often thought of to be potentially fungal in etiology. And in fact, here, this woman had been treated with multiple courses of topical and then ultimately several different oral antifungals for months before she was appropriately diagnosed as having inverse psoriasis or intertriginous psoriasis. So this is a very important one, particularly of relevance to the rheumatologist, as we'll show in a moment, because it may be one of the risk factors for development of psoriatic arthritis. Genital psoriasis, again, we don't have a lot of time to go into great detail, but I will say not uncommon. In fact, about 60% or more of our patients report having ever had genital psoriasis as part of their psoriasis. You can see some of the features here, including cracking and fissuring, that certainly lead to pain, sexual dysfunction, embarrassment. And this really has quite a high impact on quality of life, and something that if we're not asking about, our patients may or may not share with us. They may not even make the connection between the genital lesions and their psoriasis. With regard to nail disease, very, again, high level, we can certainly see classic pits, as well as distal onycholysis at the tip. We can see some oil spots here on this particular photo. And there are some other findings that may also be associated with psoriatic nail disease, splinter hemorrhages. So this is a study we did now a number of years ago, looking at subsets in the Nurses Health cohort in Boston. And you can see the majority of patients reporting plaque disease as well as scalp disease, not surprisingly, lesser palmoplantar involvement in this particular prevalence study, nail disease upwards of 23%, and of interest, a much higher than predicted inverse intertriginous psoriasis rate of almost a quarter of patients reporting inverse disease. So why does that matter to the non-dermatologist? To begin with, obviously we know how impactful psoriasis is on quality of life, and obviously it has relevance in our ability to appropriately diagnose and get patients to the right psoriatic arthritis diagnosis. That said, we also know that several of these phenotypes that we reviewed carry an increased risk for the development of psoriatic arthritis, namely scalp disease, that inverse intertriginous disease, as well as nail disease, and some other factors, including the severity of psoriasis. I raised inverse because for some of our patients presenting with a seronegative inflammatory arthritis, really getting, if we don't see classical plaque disease, it can be incredibly helpful to get the patient undressed and look for some of these more subtle features, including inverse psoriasis, that really, move us over to the appropriate diagnosis of psoriatic arthritis in a patient with inflammatory findings. So with that, hopefully I've shared with you a few morphologic variants. There is always a differential diagnosis. And so if something's not responding to treatment as you might expect, do think about, a local friendly Chat with your dermatologist or referral as appropriate. Biopsy is often helpful if there's a question. And remember that intertriginous disease may be a variety of things, including fungal or candidal eruptions. There are multiple different causes for pustular disease, including drug eruptions. Thank you for your attention, and I'm going to turn over control to my colleague who's going to take you on a tour of actually assessing and measuring psoriasis for everyone, actually. Christina.
Thank you so much, Joe. So what's important when we think about measuring or assessing severity? And I think there's kind of an approach here to think about it in clinical practice versus in a clinical trial, but no matter what, the principles still hold true. Good measures require truth. Do they reflect true severity? Are they measuring what they're supposed to measure? Validity? Do they discriminate? Can you tell mild from severe? Can you detect change? And feasibility. Can the provider do it during clinic realistically, or are they able to do it in trial? And there's other obviously attributes that are good, like reliability, et cetera. And those are three attributes are what we call the OMERACT filter. And in all measures, no matter if you're doing them in the clinic or in trials, really need to adhere to those. And feasibility is really important for clinical practice, which is why when you look at this non-Venn diagram where you see only one measure really overlaps, that trial measures, there are a lot of different measures. These are just a few that are commonly used in clinical trials right now for psoriasis. So body surface area, physician or investigator global assessment of PGA or IGA, kind of mean the same thing. PASI, which is psoriasis area and severity index, or classic plaque psoriasis measures. But as we have done the work of GRAPPA and IDIOM and others, really recognize that we need to take a more comprehensive approach and measure nail severity with instruments like NAPSI, scalp disease with PSSI and other global assessments. But in clinical practice, we don't really use many of those things. In fact, sometimes we barely even use simple things like body surface area, because honestly, all those instruments can be a little time consuming, not very feasible, and it's actually a bit difficult to know how to do all of them. And really oftentimes you just see people using descriptions like, oh, the plaques are in certain locations, or they're coarsely described as improved or not improved or the same. So I feel like even in our own dermatology world, these are kind of obstacles to people to do body surface area or PASI and PGA. So in the last few minutes that we have, I'm just going to quickly run through just some pragmatic tips on how to do this very simply, and some resources for it if you want to learn, because I think it is really helpful to have some objective measures you can use in clinic. So the first one is body surface area. Maybe you've seen descriptions of using rule of nines, where you start to go, it's 9 on the arm and 9 on that arm and 18 on the trunk. And then you say, I don't think I want to do this. But really you can do this very simply by using your handprint as a guide for defining a total body surface area. So the patient's handprint, the whole handprint, including the fingers and thumb, is about 1% of their body surface area. And you can just simply add up the number of handprints. And if you're doing it on telehealth, you can say to a patient, pretend like all of your patches could be pushed into handprint size patches. How many total would it make? And they're pretty good at it. So if they can do it, I think we all can do it. So it's really a very simple thing. If you see here, there are 6 big ovals and then 4 smaller ones, and you push them into handprint size patches, you would get about 7 full handprints. And then taking it to a photo again, just kind of in your mind's eye, thinking how you would do this, again, using his handprint as a guide, you can kind of think, how would you outline a few of the patches and then push the rest together into handprint size patches? And that area that you can see is about 6%. So PASI. So what is PASI? It's the Psoriasis Area and Severity Index. It's the most commonly used severity measure for plaque psoriasis in trials and in many registries, as well as even in regular clinical practice across most of Europe and other parts of the world. The nice thing about this tool is that it assesses both plaque qualities, erythema, induration, scale, as well as the area affected. And most physician global assessments, even used in clinical trials, don't do that. They don't count for area, which kind of leaves out an important domain. It's really pretty familiar to most investigators. It detects change when psoriasis is moderate to severe, which is a limitation if you have low body surface areas, which is a limitation in psoriatic arthritis trials where patients tend not to have as severe a disease. It has pretty good reliability. Payers often ask for it, and it is also part of some rheumatology composites. But when you look at this instrument, as I'm going to show you here, it can be a bit intimidating because you've got to rate erythema induration scale in 4 parts of the body and then do some math to figure out the area score, which uses kind of a, what percentage of the area is affected. And that takes either some math or a calculator. The good news is that we have an app for this. So Grappa a few years ago, which also created not only a PASI component of this, but also an MDA calculator, a PEST calculator, the PSET questionnaire is in there. There's other reference information. So it's a very nice instrument to use, but it can actually calculate a PASI and a BSA at the same time. Basically what you do is just go into the app, and then there's a slider to like score 1, 2, 3, 4. There's some pictures there that pop up to show you a guide for what the erythema or the scale or induration might look like. And then you can use that handprint method in the area score. So if you just put in the handprint, then at the end, you will get both a body surface area and a PASI score. So it's 2 for 1. It's pretty useful. It's a free app, and it's on both iPhone and Android. I always tell residents that are in training that this is really an important tool to understand, not just to do it. If you don't want to do it, no big deal. But it's also really important because it's a really big measure for all psoriasis trials. And for most clinical trials for moderate to severe psoriasis, patients need to have a PASI of 12, a body surface area of 10, and a PGA of 3 to get in. And PASI 75 and 90 are new, are kind of our standard and the newer endpoints. And all they mean are 75% improvement from the baseline PASI, and the PASI 90 is 90% reduction. And you can see also those correlate pretty well with a physician global assessment. So the last endpoint is the physician or investigator global. And when I say I really don't mean there isn't just one. There are many, many of them driven by a lot of industry and FDA interactions. And so I think that's confusing to people, but at the end of the day, most all of them are either a 4 or 5 point scale. This shows you a 5.0 to 4 scale, which is what the FDA in the US likes us to use. And here's just some examples of how the gradations go from 0 to 4, from, clear to, mild, which is a light pink, to light red, all the way up to really beefy red coloration. Scale goes from, no scale to very sparse, fine, not very much coverage, to more coverage, more coarse, and then total coverage where you can hardly see the erythema. Induration's a little trickier. I think if you think of this as a millimeter as a 4 and everything else is a 1/4 of a millimeter less, that's generally how we do it. So these instruments, just like any instrument, have limitations. And one of the things that they kind of fail on, which is ironic in a way, is that they don't correlate super well with disease severity from a patient standpoint or from a patient-reported outcome standpoint. So you can see here a patient who has practically erythrodermic hands has a body surface area of 2% and a PASI of 3.6. That sounds really mild. And the patient with scalp disease, a body surface area of 2% and a PASI of 3.6, inverse 1%, PASI of 1.2. But there are some new studies that have come out, one that'll be presented this year at the AAD, that really suggest, based on registry data, that patients with low body surface areas, but in special areas like this, like your psoriatic arthritis patients, actually have much worse scores on patient-reported outcomes. And even if they had all of these phenotypes, body surface area of 8%, PASI 7.2, they wouldn't even make it into a clinical trial for a moderate severe disease study. So last is patient-reported outcomes, which I'm just going to touch on, which is the future is now. This is actually a screenshot from one of my patients' charts where we use an instrument called Skindex and also PROMIS Depression and Physical Function. And high scores of the Skindex correlate with worse quality of life. Low scores are basically correlating with clearance, and you can see that it kind of goes the wrong direction. But from March of 2019 to August, I put this person on a therapy that basically cleared their skin, and you can really see how nicely their scores come down. There are very quick tutorials on how to do each of these that GRAPPA and the AAD partnered with. And that is, I think, the end of my slides. So thank you very much. And thank you, Joe, for your partnership.
Thank you.
Thank you very much, Christina and Joe. Let's just whip back to those questions that you had before the presentation now. So the first question was, are all of the following phenotypes are associated with an increased risk for development for PSA except, is it palmoplantar, inverse intertriginous, nail psoriasis, or scalp psoriasis? Please vote now. 5, 4, 3, 2, 1. And almost all of you have voted for palmoplantar, which is the correct answer. Although those of you who've been following the chat will have noticed, and we can perhaps open this up again in a second, some discussion about the answer to this question. So we'll leave Joe to just mention that. Fabian Proft has raised a question mark about this answer. Next question, please. And of these 4 questions, which is true? The body surface area and PASI correlate highly with patient-reported quality of life measures. The PASI score takes into account erythema, induration, scale, and body area involvement. There's a single common PGA, Physician Global Assessment, recommended for use in industry clinical trials for psoriasis. Or the PASI functions best when patients have a low body surface area. So please vote now. 5, 4, 3, 2, 1. Again, as before, but more have now voted for the PASI takes into account erythema, induration, scale, and body area, which is the correct answer. So we'll now move on to the panel discussion. I'm conscious that we are slightly behind time. I don't want you to overrun and you all to disappear. So we might limit this discussion and then try and pick it up at the end where we have longer. So the panelists for this discussion will be Joe Merola, you've just heard talking, Katie Leung, we heard previously, Ashish Matthew, and Martin DeWitt, as well as myself moderating. So just to pick up, Joe, that question of PPP and psoriatic arthritis, particularly the axial or SAPHO type forms, I've seen your responses. Do you want to say any more than that, really?
I'll speak briefly, Philip, and also delighted to be here with you all from Boston. And Philip, wonderful job. You're an excellent moderator. I was just going to add in here, Fabian brings up these wonderful points. I think just to jump to the point, the last one is I'm a bit of a splitter on this. And I think we need to have a better sense of what palmoplantar disease is in terms of the spectrum of palmoplantar psoriasis, really sort of a manifestation of phenotype of a plaque patient. They have plaque disease, they have some palmoplantar disease. Then, in the middle, the patient who has pustular palmoplantar disease, but in the context of plaque psoriasis, a family history of psoriasis. I think that may be its own phenotype and probably has its own genetics. And then this entity of palmoplantar pustulosis, which I think is seemingly, and again, I can't stand on tremendous data here, but to say that I think that seems to be potentially its own entity, perhaps even with a different genetic background. For example, the IL-36RN mutations that are seen in some fraction of those patients with palmoplantar disease. And I can't help but think that those are going to come clustered either with different phenotypes with regard to musculoskeletal disease and axial phenotypes, perhaps even cluster with B27, or more traditional axial disease. And so fascinating question. And I'll just say that Philip has a particular interest in this area as well. We've had some discussion about this, and he's looking into this very actively, including utilizing, for example, the PEST screening tool to actually assess whether these patients with these other skin phenotypes do in fact have increased musculoskeletal disease, particularly axial. So hopefully we'll get more data on this as interest shifts into this area, I think.
Yeah, that's a modified pest, of course, but we're looking forward to that. And we could spend a whole seminar talking about BPP and SAPHO. I'm not going to ask Ashish or Katie any this time around because we'll have longer at the end. But one quick question to Martin. We're all rheumatologists. Well, not all, but the majority of people on this call, the participants, will be rheumatologists. And we're not trained to examine skin. Is it your experience that the rheumatologist isn't interested in your skin, or do they always pay attention to the skin when you go for consultations?
No, definitely not. There are often consultations that I have where the skin is not discussed and is not asked for. I never underwent a PASI or a BSA score, so I found the explanations very enlightening. But I must say I have now a younger rheumatologist who asks more frequently for the skin. So even though she doesn't do a formal assessment, she's more interested. So I think there is a change for the better, but it's still ignored, I feel, in many occasions.
I think your new rheumatologist must have heard Alice Gottlieb talk, because Alice always likes to say, how can you rheumatologists treat the patient if you don't look at the skin? And this is true. Whatever drug we choose has to keep the skin in mind. And I think that's a very important point. Folks, I'd love to carry on this discussion, and we will come back to it, but we must hurry on to the final presentation before we do. So I'm sorry, Ashish and Katie, but thank you for your participation. So we'll move on to the final session on axial spondyloarthritis. Here are the pre-test questions, the pre-presentation questions. So the first question is about MRI. An MRI finding of bone marrow edema in the posterior lower ilium and anterior upper sacrum can, and your options are, allow for early diagnosis of axial SpA in inflammatory back pain, be used for assessing disease activity of axial SpA, distinguish axial SpA from degenerative pathology, lead to overdiagnosis of axial SpA, or are you unsure? So please choose your answer now. There's one answer, and you've got 5 seconds. 5, 4, 3, 2, 1. So the majority, just about, I think I can just scroll down there, I chose answer 1, allow for early diagnosis of axial SpA in inflammatory back pain. Next question. The next question is about axial mobility measurements in axial SpA patients. Axial mobility measurements is a measure of change, not status, cannot measure disease activity, is a measure of structural damage alone, depends on disease activity and structural damage. There's one correct answer. Please answer now. 5, 4, 3, 2, 1. And the answer that majority of you have answered is depends on disease activity and structural damage. Let's see how you get on after the presentation.
Hello, my name is Atul Devdar. I'm a professor of medicine at Oregon Health and Science University, Portland, Oregon, and I'm going to discuss the topic assessing disease activity in daily clinical practice, axial spondyloarthritis. So the first question we have to answer is, why should we assess disease activity in clinical practice? And what this cartoon shows us is the relationship between the disease activity or inflammation and damage and disability. At the lower left side, what you see is a patient who's disabled, and we are trying to avoid disability in our patients. It also shows that inflammation leads to reversible disability. At the same time, inflammation can lead to irreversible damage, and damage can lead to irreversible disability. So if we have to avoid disability, we have to prevent and treat the inflammation actively. Now, we are rheumatologists. We treat inflammation better than anybody else. And that's the reason why we should be assessing disease activity in clinical practice so as to prevent damage and so as to prevent disability. So then the next question is, how do we assess disease activity and how should we assess disease activity? So on the left-hand side, you see what happens in daily practice. We take the history, we do physical examination, we do labs, and then we do imaging at some times. All of this gives us some idea about the disease activity, history like pain and swelling and stiffness and fatigue, and the physical examination, and then the inflammatory markers. MRI can give us some idea about disease activity. But then what will add value to what we routinely do? And the answer is the composite measures of disease activity, BASDAI, ASDAS. And I'm going to also put in the plug for RAPID-3 as a method of assessing disease activity. So in the peripheral skeleton, you have already heard about this in the psoriatic arthritis talk. 66, 68 joints, enthesitis, and there are several enthesitis indices and dactylitis, and I won't go into the details of those. For the axial skeleton, spinal mobility measures are what we do. Think about it though. Do spinal mobility measures really assess disease activity? And we'll come to this in a minute. SED-rate, CRP, yes, and then there are those BASDAI, ASDAS, and RAPID-3, the composite measurements of disease activity. Before we go any further, I want to make an important point. We should not confuse change measures versus status measures. Change measures don't tell us anything about the patient's current status. They only tell us how much they have changed. Have they improved by 20%, 50%, 40%, etc.? Examples are ACR 20, 50, 70 or ASAS 20, 40, etc. On the other hand, status measures don't tell us whether the patient has improved or not, but status measures tell us how the patient is doing. All the disease activity measures are status measures. So peripheral skeleton, and I'm not going to go into the details of this. You already have heard about this in the psoriatic arthritis talk. For the enthesitis, in my practice, I do a hybrid measurement of Achilles tendon, plantar fascia, quadriceps, patellar tendon, lateral and medial epicondyle, and I do the joint counts. For the axial skeleton, I do the axial mobility measures. Now, axial mobility measures, do they really measure disease activity alone? The answer is no. They do have, the disease activity definitely has an effect on the axial mobility measurements, but the axial mobility measurements depend upon the damage, and they also depend upon the age, the sex of the patient. What I do in clinical practice is tragus to wall, occiput to wall, 10 centimeter Schober stress, and lateral spinal flexion. That's what I do in my daily practice routinely. That brings us to the disease activity measurements such as BASDAI and ASDAS. BASDAI has 6 questions. The scale is 0 to 10. Completely patient-driven. ASDAS has 5 elements. There are 3 questions from BASDAI, and there is 1 extra question about patient's global disease activity. And then there is either SED-rate or the CRP. This is BASDAI. It takes about 2 minutes for the patient to fill out. It takes about 1 minute for us to score. The minimal clinical important difference, or MCID, is 1 centimeter. ASDAS is another very validated measurement. It was devised because BASDAI is purely patient-driven. So this one has, as I said, 3 BASDAI questions, 1 patient global activity measurement, as well as CRP or SED-rate. And it has a very complicated formula. These are the cutoffs, and I want you to look at the bottom part, the 2018 update. ASDAS of less than 1.3 is inactive disease, 1.3 to 2.1 is low disease, 2.1 to 3.5 is high disease, and anything above 3.5 is very high disease activity. Now, ASDAS is a status measure. It tells you about the patient's disease activity. However, ASDAS can also be used as a change measure, and here it is shown. that the change in ASDAS of 1.1 or higher is clinically important improvement, and change of 2 or higher is major improvement. So the same measure we are using as status measure and change measure. So what is feasible and what is simple and what adds value? Now, ASDAS is validated. It definitely adds value. But in the United States, we certainly don't have C-reactive protein available at point of care. BASDAI is validated, simple, feasible, and does add value. We started wondering whether RAPID-3 can be used because it's the most commonly used tool in the United States. And we did a study on 157 ankylosing spondylitis patients that we followed for about 5 years, and we did cross-sectional longitudinal data about the BASDAI and the RAPID-3. And we found out that RAPID-3 correlates very well with BASDAI, and it has an advantage of providing information about the patient function in addition to the pain and stiffness. We also found out that BASDAI of 4, which we take as anything above 4 we consider as active disease, correlates very well with RAPID-3 of 3.3. Remember that BASDAI of 4 correlates with RAPID-3 of 3.3 and higher. That brings us to the next big topic, which is MRI of the sacroiliitis. Now, MRI of the sacroiliitis, or MRI of the sacroiliac joint, I should say, is the only objective sign of inflammation at the target organ that we are interested in axial SPA, and that target organ is sacroiliac joints. The definitions are changing. These ones are the newer definitions: the bone marrow edema, abnormal fluid signal indicating active sacroiliitis, shown on the top left. Now, this is looked on the STIR image, which is a fat suppressed T2 weighted image, and the next 3, the right upper and both lower, are on the T1 weighted image where the bright signal is fat. And that particular figure, or those particular signal and images, are important for erosions, ankylosis, fat lesion, etc. These are post-inflammatory changes. When should we reorder an MRI? We can order MRI for diagnosis, but we are thinking about disease activity. The 2019 update of the ACR SAA Spartan treatment guidelines say that routine monitoring of MRI is not recommended. They say we conditionally recommended obtaining a spinal and pelvic MRI to assess activity while the patient is on biologic only if you are suspicious whether, or if you don't really know whether the patient's condition is active or not. That's the only time that you would repeat an MRI in daily practice. I want to show you a few slides about the caveats. All the disease activity measures in axial SPA have caveats. So apart from CRP and sacroiliac joint MRI, everything else is patient reported, and that heavily is affected by the patient's mood, anxiety, depression, and distress. Daily stressors affect the patient's fatigue, pain, etc. On the right hand side, I have given you 2 references which show the relationship between the disease activity measured by BASDAI and the psychological status and stressful life, etc. CRP, which is an objective measure, is neither sensitive nor specific. MRI is too expensive. We don't repeat it routinely. So ultimately, for disease activity, clinical judgment is the key. I want to give a shout out to this paper by Jean Liu, and this was published last year in ACR Open Rheumatology. Effect of stress and anxiety on the axial SPA disease activity. So Jean looked at the SOAS database and looked at the patients in the SOAS database during the pandemic. And she found out that after adjustment for potential confounders, those with higher levels of stress had 0.54 point higher BASDAI compared to those who had lower levels of stress. In other words, stress, depression, anxiety can increase disease activity. So ultimately, it's your clinical judgment that is what is important. Well, what about CRP? I mean, that's objective, correct? So there was a study that was done on tocilizumab, an IL-6 receptor antibody, and they found out that it works dramatically on ASDAS reduction because ASDAS is so much dependent on the CRP. However, tocilizumab had no effect on the patient-reported outcomes. So CRP might drop like a stone in drugs that reduce the CRP or act on the IL-6, but that also is a caveat. That brings us to MRI, and MRI has caveats too. As you know, active MRI or positive MRI, if there is a signal on the stir image in the posterior lower ilium or anterior upper sacrum. Those are the two areas which are most commonly affected, even in normal people, in athletes, in mechanical back pain, etc., etc. So two white spots on the MRI on the stir image is objective but not specific. In other words, every measurement for disease activity in axial SpA has caveats. Beware of them. Finally, how do we assess disease activity in the era of telemedicine? Telemedicine is here to stay. Even post-pandemic, we are going to be using telemedicine as we are getting more and more comfortable. Here, history becomes most important. I ask my patient about their pain, their spinal pain, and I, in fact, fill out the BASDAI and RAPID-3 by asking the patient directly questions, and I'm filling it out by asking them those questions. There is a brief physical examination I'm going to show you on the next slide, what you can do on telemedicine, which gives you an idea about the disease activity. Ultimately, you tell the patient, send me the photos of your swollen joints and rashes and etc. And labs, of course, are become very important. Here is my patient who's showing me, and actually you can see even my photograph in the lower corner in those pictures there. The physical examination that I do are MCP, PIP, DIP, synovitis. Here the patient showing me his hands and then showing me this way about the knuckles. Patient reported swelling, dactylitis, deformity. I asked them, send me a picture. Is any toe swollen like a sausage? And then the palm size 1% body surface area for psoriasis is also very important. We are learning different ways of doing physical examination during virtual visits and assessing the patient's disease activity. In summary, persistently high disease activity in axial SpA leads to disability directly, that's reversible, and indirectly through skeletal damage, and that is permanent. We need to prevent that, and that's the reason to assess patients' disease activity in daily clinical practice. In daily practice, we assess the axial SpA disease activity by history, physical examination, peripheral and axial skeleton in examination, as well as lab investigation. And then we should be using the composite indices of disease activity, such as BASDAI, ASDAS, if it is possible, definitely. And RAPID-3 is what we use along with BASDAI. Longitudinal assessment and tracking patients' progress becomes very important. MRI of the SI joints and spine should be reserved in patients on biologic where disease activity is unclear. Thank you for listening.
Thank you very much, Atul, who is of course not with us today. We have a very able stand-in with Ashish Mathew. Let's just do the questions again. So the first question was MRI finding a bone marrow edema in the posterior lower ilium and anterior upper sacrum can, and you've got 5 options, allow for early diagnosis of axial SpA and inflammatory back pain, which was in fact was the most popular result last time. Be used for assessing disease activity of axial SpA, distinguish axial SpA from degenerative pathology, lead to overdiagnosis of axial SpA, or if you're unsure, tick the last box. Please vote now. 5, 4, 3, 2, 1. And we still have a winner in, as far as I can see, allow for early diagnosis of axial SpA and inflammatory back pain. The correct answer, of course, as we've just heard from Atul, is that if you find only MRI bone marrow edema in those sites, it can lead to overdiagnosis. Because if you just depend on bone marrow edema, that is not sufficient, as we heard from. We need to have the whole clinical picture, and that you can see bone marrow edema in those particular sites in healthy volunteers and in athletes, and particularly in degenerative as people get older. So just MRI of bone marrow edema in those sites can lead to overdiagnosis. Next question. So we've heard about axial mobility measurements from Atul. So axial mobility measurements in axial SPA patients is a measure of change, not status, cannot measure disease activity, is a measure of structural damage alone, or depends on disease activity and structural damage. Please vote now. 5, 4, 3, 2, 1. And the majority have taken the correct answer, which is number 5, depends on disease activity and structural damage, as we've just heard. So any structural changes will contribute as well as ongoing disease activity. So let's now move to the final discussion. We've got another 10 minutes or so. We can include questions on axial SPA as well as psoriasis and psoriatic arthritis. So please, if you've got any burning questions, put them in the chat for the group to discuss. So we're just waiting for the discussants to come up here. There's been one question in the chat about a point of care CRP measurements facilitating the measurement of the ASDAS. As we heard from Atul, one of the disadvantages of the ASDAS is that you have to send off a test for laboratory assessment. But there's a question here about point of care CRP measurement. I don't know if any panel members have any experience of this. It would certainly be of use in the PASDAS as well. Joe's nodding his head. Ashish is not saying anything.
No, actually it was a good learning point for me as well, because I've been doing ASDAS CRP, but again, I think Atul had a strong point, because we won't really be having the CRP with us up until maybe the following visit. So that's kind of, but this sounds pretty interesting, and yeah.
Probably expensive, of course. Katie, we're talking about dactylitis. There's a question here in dactylitis. I mean, what's going on in a dactylitic digit? And if you're doing an assessment of dactylitis, how many swollen joints do you count for a dactylitic digit? Is it 1, 2, or 3?
Okay, I think it's important to recognize dactylitis and peripheral joints are different domains. So they are all under the musculoskeletal disease activity, but we assess peripheral joints separately from dactylitis. Although a long time ago, we always say that dactylitis would count as an active joint. So I would count this peripheral joints, swollen and tender joint count separately as compared to dactylitis. Photodactylitis is actually not in the synovium at all. If you look into MRI, there are edema in the soft tissue, in the tendon, tenosynovitis, as well as around the periarticular areas. So it's very extensive. So the assessment is really at the base of the finger that you are pressing on to assess whether there is tenderness, and also looking at the circumference of the digit. So I would not say that it's counted as one active tender joint or swollen joint, but it's separately. The most easy way is just count the number of fingers or toes that are affected. Is that answered?
Yeah, and I mean, I know that in clinical trials, companies, if you find dactylitis, they allow you to score 1 tender and swollen joint if the digit's tender. But I think it does vary between digits, and the work we did with MRI showed that there was some synovitis in the joints as well. I have a question here for Joe. Treat to target.
Yeah.
What do you use as a skin target in a treat to target scenario?
Yeah, it's a wonderful question. So we do have some guidance on this, more consensus driven than anything else. But in the US, at least, the National Psoriasis Foundation has recommended a treat to target of a body surface area of less than 1% at 3 and 6 months after seeing the patient. And there's sort of an acceptable alternative of a 75% improvement in BSA at that 3-month time point. Alternatively, other groups have come up with these discussions, and I think There's a Canadian guidance around just clear, as the goal, and there are many others. I think the easiest, most feasible thought is just, in my opinion, is a shared decision-making, discussion with the patient about how clear they want to be, and frankly, and that's the target. Not to undermine anyone's effort in that area, but I think most patients want to be as clear as possible, and I think getting to as clear as possible is ideal, and in some cases a bit aspirational. But with some of the interventions we have now, I think we can often get there. So that's what I keep in mind. And you mentioned Alice Gottlieb earlier. I'll say, I do think our patients really do care about their skin disease. So I'd encourage all of my rheumatology colleagues to do indeed, make sure that you're aligning with the patient's goals, and either, collaborate with a dermatologist to get them to that goal, or own it as such. And the MDA includes a very similar endpoint as well. So.
Just a quickie, Joe, here from Ali Mohammed. Why do you use CRP to measure inflammation in skin disease, or not?
I'm a biased cohort here. The quick answer is no. I mean, most dermatologists do not routinely check CRP, certainly as any direct correlation to the skin inflammation burden on this, systemically per se. I think, in our arena, of course, we have a combined clinic model. We're screening everyone for PSA, and we will use it, of course, in our assessment of their potential underlying, arthritis, and whether or not it correlates with a more erosive phenotype damage, et cetera. But I'd say in general, most dermatologists are not routinely checking it. If they are, it's sort of, part of the comorbidity assessment of cardiovascular disease. And then typically they're co-managing with either the primary care or a cardiologist as such, but not generally, no, I would say.
I'm coming to you last, Martin, so don't go away. But Ashish, there's a question about what do you use for axial disease activity measures in psoriatic spondyloarthropathy? Is anything different from what you'd use in axial ankylosing spondylitis?
Not at the moment, I would say, because I'm just waiting for the trial to kick off. I'm sure Fabian is the one who asked that question. He himself is part of the trial, and I'm sure we have the AXIS trial to know more about axial PSA, in which we are doing MRIs, and hopefully. But as of now, I simply go by the ASDAS and BASDAI for now.
Yeah, I think that's true, Katie, isn't it? We just use measures that are currently used in axial spondyloarthritis. Yeah. I'm conscious that we're getting near to time. We have a question from Fatima Haji asking about a patient with axial spondyloarthritis and peripheral arthritis and sternoclavicular osteitis, but no evidence of skin psoriasis or family history. Is this CRMO? Difficult to say, Fatima. We'd need to have more information, more imaging. We'd need to examine the patient ourselves, of course, but thank you for that question.
Well, and Philip, just to that point, I would also ask if there's been any, not just psoriatic skin disease, but also look for severe, severe acne, or even, I think, history of severe acne, or even some patients with PG.
And tonsillitis, of course, can't it? Current tonsillitis.
Yeah, there may be other correlates.
Yeah. Thank you. Thanks for reminding me about that. So we're almost finished now, I'm afraid. I know, and the questions are actually still coming in, but I want Martin to have the final word. And I want to come back to this question of, I know that we're still in the COVID era, we've still got a lot of telemedicine going on. I just wanted to know how you would feel about having to self-assess and carry on self-assessing, and then maybe trigger your rheumatologist when you needed them. So in other words, you would govern the appointment schedule, not the rheumatologist or dermatologist. How do you feel about that?
Yeah, I found it fascinating to hear the discussions at the start of this seminar about the self-assessment. And I think that although it might be promising, and I know that there are some studies specifically focusing on joint self-assessment. I personally find it quite hard. But for me, I think it is essential that also patients are educated first to do the self-assessment. So even for a PASI or a body surface area, just the first time you should do it together with your physician. And then afterwards, you can rely on, because then you can see whether there is a difference. And this education part, I think, is very important to make sure that patients do the self-assessment properly and that the outcome is relevant. Yeah.
Okay. Now that's good. That's good advice. Thank you very much for that. I'm going to have to call a close now because it is 1:30 my time. We've had an hour and a half. I'd like to thank the speakers and the discussants. I'd also like to thank the content creators, the patient partners, and I'd like to thank you, the audience, for putting in your questions. You've been a great interactive audience. I've also like to thank Nucleus for their technical support, which is excellent, for Lisa and Janine at Spartan and Grappa for really putting this whole thing together. And if you wish to join Spartan or Grappa, then please look on the websites and think about that. The presentations you've seen today will be available on the Grappa website and the Spartan website in due course. And there'll be a survey coming along. Please complete that as to give us a bit of feedback as to how we've done today. I'd like to thank Pfizer again for providing that support. I'd like to remind you that we've got some upcoming seminars, which you can see on the screen now. There are 3 more of these, an update on comorbidities and the burden to patients. There is a hot topics on race, age, and sex considerations, and then a global perspective on new therapies in development. So once again, thank you, and I hope you all have a good day.